Hello, good afternoon, and welcome to the Texas Oncology Foundation Survive and Thrive webinar series. My name is Kelly Condon, and I am the program coordinator for the Texas Oncology Foundation. Thank you for joining us for today's webinar presentation with Tani Bahti, who will be leading our discussion on straight talk about the dying process. The Texas Oncology Foundation is dedicated to providing support to cancer patients in the communities where they live, work, and receive treatment. And these Survive and Thrive programs are just one of the ways we are active in communities, providing both resources and support to all of those involved in the cancer journey. We want to give a big thanks to Texas Oncology for their continuous support and partnership in these programs as well. I want to take a moment and just find out, who do we have on this call with us today? You're going to see a poll question pop up on your screen. Please click your answer. We want to know, do we have survivors, caregivers, healthcare providers? And if you are multiple of those, click multiple answers. Awesome. It looks like we have a pretty even split of people on this call. I love that. Thank you for being here today. Before I introduce our speaker, I just want to give you a few housekeeping tips and tricks. Throughout this presentation, if you have any questions, please submit them. We are going to answer questions and respond to all of your comments at the end of this presentation. But on your control panel, you will find a questions tab, and this is where you can submit all of your questions, all of your comments. And like I said, at the end of the presentation, Tani will respond to them. If you are experiencing any trouble, such as your windows disappearing or the slides are not advancing, simply closing and reopening the webinar window will usually fix this issue. If you're experiencing problems with your audio, the best solution is just to call in and listen over the phone. Again, going over to your control panel, there's an audio tab. And if you select phone call, the number that you will need to use will show up. There is a handout provided for this presentation. Tani has provided a resource handout. Again, going back to that control panel, there's a handouts tab. During this presentation, you are going to be able to view, download, and save that. So it will not be available afterwards. However, download it and save it during this presentation, and that way you can keep it. Lastly, this webinar is being recorded, and we are going to make the online archive available after this live version. It will be sent to everyone who registered for this presentation in a follow-up email, and then it will also be housed on our Texas Oncology Foundation website, which is texasoncologyfoundation.org. And then if you go to the Programs tab, which is along the top, and then select Survive and Thrive Webinar Archive, which will be on the left side of your screen, then you will find all of our past webinars. Like I mentioned earlier, we are so excited to have Tani Bahti with us here today, leading our presentation. She has been a nurse for 43 years now and has made it her focus to improve end-of-life care. And she has actually spoke at a few of our Foundation's Survive and Thrive symposiums. And so, Tani, we are so thankful for your continued partnership with our foundation and for participating in today's webinar. So I'm going to hand it over to you and let you do your thing.
Great. Well, thank you so much for letting me talk about what I think are some of the most important conversations I've ever had in my work in oncology and in hospice, certainly, is being able to talk about dying, because it could be a lot of participants there feel like Woody Allen when he said, you know, I'm not afraid of dying. I just don't want to be there when it happens. Because a lot of people may have a belief system about what happens after you die, but the question is, and the fear comes in as to, what do I have to go through to get there? And if you don't have that information and you are fearful or have misinformation or lack of information, that's really going to impact decision making. So I love to respond to the fear. And the most important thing to know, and the bottom line of my presentation today, is that there is more wisdom in your body than in your deepest philosophy. Your body knows what to do. It knows how to shut down. So just like it has to go through certain stages to be born, then it also has to go through certain stages to shut down and to die. So we look at what are the natural and normal changes your body's going to go through that we don't want to interfere with lest we inadvertently create discomfort. And that's often around food and nutrition. And what are the changes that if they do occur, absolutely we want to be able to provide the best care possible. And let me just put a little caveat in here. Dying is not synonymous with pain. I have had plenty of patients who didn't even take so much as an aspirin as they were dying. It all depends on the disease process. But if pain is a part of the process for yourself or somebody you care about, know that find the right clinician to handle it, because it's never acceptable for anyone to say, there's nothing more I can do. So again, I think the most important question I respond to is when a patient asks me, how am I going to die? Because dying looks different with different diseases. It looks different to die of a brain tumor than it does to of emphysema, than it does to dementia. But when you understand how the body changes on those and can talk about what's the best care possible, the fear goes away and the patients and families are empowered with, I understand what's happening and I know what to do about it. Now, asking this question may be difficult. So as you as a clinician, sometimes what I will do is extract the question and say, do you want to know what to expect? And invariably the answer is a resounding yes, because we've got to let those fears out, and then it, again, will really impact the care and also the decision making. Also, understanding what to expect has another really important reason, because they need to know, because they may need to choose. So for example, it may, with Alzheimer's or end-stage dementia, the most common natural and normal cause of death is pneumonia. So it may be easier to allow the pneumonia to advance as opposed to treating that and have an advancing disease. It may be easier to stop blood transfusions for a bleeding tumor because it's more comfortable to die of anemia than have that tumor growing in a stomach per se. It may be easier to die of kidney failure than it is to continue to treat a liver disease. So understanding what those possible pathways may be will really help that decision making. So understand also that when we're dealing with a chronic or advancing disease, every time there's a change in function, it's a loss. It's going to create loss and grief and fear for the patient and for the family. And we need to let them have voice for that before we can move on to say, okay, yes, this has happened. Now let's talk about the next step and what can we still do. But just know that that fear is going to be natural. So what I'm going to do is talk about some of the bigger changes in dynamics physiologically, communication-wise, and even on the mysteries of dying. I won't be able to cover all of it in my short time frame, and that's where my resource page comes in if you want to download it, because my videos or books will give you much more detail on that. So let me start with some of the early changes, and sometimes that's just a change in energy. Again, it may happen short time before death, it may be many months or years before that. But bottom line is, when you're dealing with a chronic advancing illness, the old ways don't work. Now, what I mean by that is usually like if you've been ill, you had surgery, there's a recuperative time. You start to build up. You start eating more each day, you start exercising more each day to build back up. That doesn't happen with end-stage chronic illness. So we really have to rethink the way. So what I tell families, I try and keep it simple, is say, the energy your loved one has is like money in a bank. Here's what they've got today. How do you want to spend it? Now, if I, as a well-meaning daughter, say, oh, Mom, you got to take a shower each day, and I don't want you using the wheelchair, I want you walking to the table for breakfast. Mom may have spent all of her energy by the time she gets to the breakfast table. Now she's too tired to eat. So inadvertently, I've worked against her. So again, only the patient knows what it's like inside their body. Let them dictate. Boy, you got some friends coming from out of town today you haven't seen in a long time. Great. Rest in the morning. Save that energy for the afternoon. Look at what's really important for them, because you've only got so much energy. Part of that is also, as the energy diminishes, people are going to be less active. And sometimes there's this feeling like, well, you've got to at least get up into a chair. Well, again, let the patient be the expert. I'll maybe have a lady who's very bedbound, and the family goes, well, she's got to at least get up. So I'll show them how to feel her pulse, check her heart rate. The normal heart rate is 60 to 70 beats a minute. but their mom's heart rate might be 90, 110, 140. And I say, that's the heart rate of somebody who's running a marathon. So just lying there, your mother's body is working so hard. It's like she's been running that marathon and she hasn't stopped in a week. Now it's easier to understand that getting her up and out of bed is far beyond the limits of what she can do. So it's really honoring that person and realizing that, again, that rest is not them being lazy, being withdrawn, or anything else. That's simply their time, because what's going to be happening is they're going to start sleeping more and more. Now, this can be kind of tough on folks because, we see the Hollywood deaths where people are, pretty coherent and say something profound until the moments of death. I think I've seen that once in my 43 years of nursing. But it's distressing for the family because this is their last time with somebody. And as their loved one is sleeping more, they think, oh my gosh, what's wrong? You're over medicating them. Well, no, I let them know ahead of time. This is the natural process. And very often we say, if we had a choice, we'd rather die in our sleep. Well, that's the wisdom of the body. That's essentially what it does for you. You start sleeping more and more and more until you just stay asleep. You go into a coma. And depending on the disease process, that coma may last minutes, it may last days. But basically, it's in that coma, in your sleep, that your body will continue to shut down. So for you, it's comfortable. But it's difficult for the family who's thinking, wait a minute, these are my last times with you. I need to be able to talk with you. But just be aware of that. But also be aware that when somebody does go into a coma, they can still hear you. And they can still feel your energy. So even if you've got there late, even if they've had dementia, continue to talk, to touch, and to hold. Sometimes it's easier to talk to people when they're no longer talking back to you, right? Depending on your family dynamics. But talk is really important. I'll go in with families and I'll help facilitate this by saying, tell me your favorite story about your mom. And that does two wonderful things. One is, in the telling of that story, it brings up the energy in the room because you can't help but feel good about telling those stories. And then the other benefit is the person who's dying gets to hear how they'll be remembered. So get them talking. And then touch. Touch is so important. There are the occasional patients who don't want to be touched. They'll pull back and you'll know that. But mostly people are not being touched enough and not being held enough. I remember walking down the hallway in a hospice once, and this lady was sitting at the bedside of her husband of 64 years, and her little hands went through the side rails to hold on to his wrist, and she was in pain. And I just walked in there and I said, do you need to climb up there and hold him one more time? And she said, oh, yes. So, I helped her up. She held the love of her life while he was dying. What an important memory for her, and how wonderful for him to be embraced in that love while he was dying. Difficult, yes, but what a good memory. So we have to allow people that space that there's nothing strange or wrong about that. We naturally tell mothers who are losing their babies, hold them. But I got to tell you, if I'm 93 years old and it's my 70-year-old son that's dying, that's still my baby. So as much as you can encourage and normalize or help people get up there and touch them and talk with them and hug them, move the tubes, etc., that will be an important last memory for anybody. And even after death, maybe the family wasn't there. Maybe they're in the hospital or in the clinic or something. Put down the side rails. They're no longer fall risk. Straighten out the bed, make sure everyone looks good, and then go in with the family and touch them, that person yourself, and talk with them and encourage them then to give them permission to also continue to talk and continue to touch or to continue to hold, because that really helps with that closure and, again, that final memory. Okay, changes in eating. Wow, this is always a biggie, and this is where there's invariable conflict. Now, what I'm referring to as changes in eating naturally as a result of disease progression. I'm going to assume that you've already ruled out reversible causes because we need to look at that. Is it pain or nausea or dry mouths or sores or anything else? We need to tend to that. But if they're simply not eating because there's at that point where they just don't want anymore, That's a very important place to be aware of. And this is a really difficult dynamic for families, because what they see is their loved one losing weight and they think, oh my gosh, they're starving to death. So here's the mantra. They are not dying because they're not eating. They're not eating because they are dying. When the body starts to shut down, and again, this may be weeks ahead of time, it cannot process food as it normally does. If you push food when the body says no, you can cause them to cramp up, bloat up, throw up. And that wasn't promoting the comfort that you wanted. But we don't know that. We keep thinking, eat, you'll feel better, right? So I, as the attentive daughter, go, okay, Mom, just one more bite. Mom may still eat that bite, even if it makes her feel bad, because she's afraid to upset me, and that I will withdraw care. So it's a very important dynamic. Let the person be the expert as to whether they're going to eat or not, because what will happen then is that we're reversing what the blessing of the wisdom of the body is, which means that when you're not eating, you go into ketosis. That's what the Atkins diet and those things do for you. When you go into ketosis, it releases your natural endorphins, your body's morphine. It promotes a sense of well-being and a sense of comfort. So isn't it cool that that's how your body's going to take care of you? If the person says, I'm happy with one bite or nothing, we need to tend to that. We can't judge them based on us. We have to just say, if you're comfortable, that's what I need to hear. Because let's talk about some of the myths about this. Tube feedings, for example. I mean, there are roles and places for tube feedings in healthcare, absolutely. But end-stage illness, end-stage dementia is not one of them. When somebody is starting to have difficulty swallowing, we think, oh, got to put the tube feeding in. Well, guess what? They're actually more likely to have complications and die sooner as a result of tube feedings than if you did not do it. So they actually live a shorter amount of time than a longer. Because what happens is, well, let me give you an example. If you go to an all-you-can-eat buffet, you can pig out all you want. But there's going to be a point that your body says, don't send any more down here. I can't take any more. I'm going to send it right back up, right? So you naturally stop eating. But with the tube feeding, you got a tube in somebody's stomach, and it keeps pumping and pumping and pumping. And they don't have the ability to naturally stop. And so that stomach can fill up, go up the esophagus, and then that fluid can go into the lungs and more likely to get pneumonia or other issues. So there are places for tube feedings, but end-stage illness is not one of them. Use of supplements. I've gotten families saying, okay, it's okay that they're not eating, but we've still got these 20 supplements over here. Now, supplements do not take the place of food. In fact, if you are not eating and drinking, the supplements are going to be worthless anyway, because you need a certain amount of food and fluid to absorb them in the body. But if you try and force supplements on an empty stomach, wow, that can create so much nausea that, again, you've worked against it. So when they're not eating, forget the supplements. That's not what's going to help anything at this point. And then here's the chemical change that's going on in the body. And we see this especially a lot with our cancer patients. The body's wisdom, what it does is it releases something called cytokine, and it does two things. One is it blocks their desire to eat and drink, which is why they're perfectly happy not eating. But also it's to block their desire to eat and drink and the absorption of it. So at this point, if you start pushing food when the body says no, it's really going to respond, because it understands that the only cell in the body that's going to feed and benefit is the cancer cell. Years ago, I was working at a cancer center. This young woman had a tumor in her groin, and she was at that point of really wasting away, and we thought the best medical intervention was to give her total nutrition through an IV, which we did. The next day I was on duty, that tumor had tripled in size. We, in fact, had fed the tumor. We had done nothing for her comfort. In fact, we had increased her discomfort, but we had fed the tumor. So that's why we have to really pay attention to the body's wisdom if we're going to promote the best comfort possible. So eating is really part of how we nurture. So let's replace it with something else, brushing your hair, going through a photo album, getting a massage. There's other ways to showing love other than pushing food. And that's an especially important dynamic for those of us as professional caregivers or professionals to watch the dynamics in family. Give them something that they feel they can do to contribute to their loved one's well-being. Okay, so it's bad enough mom's not walking enough, she's not eating enough, now she's not drinking. So again, it's going to generate some fear. They know that the end is probably getting a little closer. And there's a lot of myths about dehydration, of being miserable. So what's true is, I live in the desert. If I go out and take a hike and get lost, you bet that dehydration is nasty. I get thirsty, I can start cramping up, I can start having seizures. But the natural dehydration that accompanies the end of life is very different. It also releases those endorphins which promote that sense of well-being and really helps benefit the body. Because remember I said that heart was working really hard, that heart rate? Well, it's the heart that has to pump the fluid through your body. If you start giving it artificial fluid or more than it can handle, it says, I can't handle this. I'm going to shunt this to some other part of my body. So guess what? You start getting swelling. So here's the complications of artificial hydration. You get more secretions, which means more nausea and vomiting, more incontinence, the swelling, and then shortness of breath because it backs into the lungs. So the benefit of natural dehydration is less secretions, less incontinence, less skin breakdown, less swelling, less shortness of breath. So again, we have to really pay attention to where the body is at any given time. Now, just a little note, bowels and bladders don't stop until the body does. Even if somebody's not eating and drinking, they're still going to produce some urine. It's going to be a darker color, probably a little more odoriferous, but they are also still going to produce waste. And so I've had families go, well, no, they haven't had a bowel movement in a week because they haven't eaten in 2 weeks. Well, guess what? Your body still produces waste, even if you're not eating. And a little bit of waste creates a rock, and a little rock can wreak holy havoc. So that level of constipation, especially for the frail elderly, can create such discomfort that it almost looks like a psychotic reaction. So that's why in hospice, we're really big on bowels, that we make sure that if they haven't had something every 3 days, that we're going to give them something to make sure that the bowels keep flowing easily. Okay, responding to fear of suffocation. This is a biggie if I've got someone with emphysema, lung cancer, whatever, because they're scared. And understandably, because what they've been experiencing is that they're breathing less and less well over time. And their fear is, gosh, I'm going to get to the end and I'm going to be gasping for breath. So knowing that, I can intervene now and talk again about the wisdom of the body and how to manage that. When you are dealing with end-stage lung issues, again, get into a hospice so that we know how to give you the right medications and oxygen to be able to manage your breathing and anxiety, but also understand how the body's going to work with you. So what happens when you're actually actively dying? Your oxygen level starts to drop. That's what the dying process is. Your oxygen goes down, your CO2 level goes up, and at that point you go into a coma. It's awesome. Struggle is gone, you're breathing easy. No biggie, you're in that coma. But what happens too often, especially if someone's in a hospital, is that we put that little oximeter on their finger that measures the oxygen, and when it starts to go down, which it should be, it starts to beep. And we start freaking out about the beep, and we start cranking up the oxygen and cranking up the oxygen. And what we're doing is not promoting comfort. Look at their face. What we're doing is we're prolonging the dying process. So if somebody's actively dying, do not allow an oximeter on their finger, please. Just look at their face and know that there's a natural process to that. Now, what will also happen is that there could be a change in breathing patterns. And again, how it changes is dependent on the disease process that's going on and the chemicals being released. But you might get rapid short breaths, you might get very long breaths and what we call fish mouth breathing, or we might get what we call Cheyne-Stokes breathing, which is irregular breathing, which is they start breathing slower and slower and slower, and then suddenly there's gaps of 30 seconds, 60 seconds, and suddenly they breathe again. Bottom line that you need to know is they're not struggling for breath right now. The changes in breathing patterns are simply related to the chemicals in their body, period. So know that. You will look at them to see any levels of distress. What is difficult, and this is really only on the witnesses, not the patient, is if somebody has what we call the death rattle. So remember I said that sometimes people get overhydrated, especially if they've been in a hospital, and there can be fluid, in their lungs, or it could also be the fact that they're not swallowing now. So they're starting to have saliva bubble up and make noises on the esophagus. The person's usually in a coma at this point, so it doesn't bother them. But for the families, it's a wet snore, and it's very distressing. So we don't usually suction it because that's invasive and uncomfortable. We'll try and position them. But we also don't want to freak people out with that noise. So what I usually recommend is counter noise. My favorite counter noise is get people to tell stories. Talk, sing, laugh, cry, whatever you need to do to take the attention off that noisy breathing. If you want to put on music, great. But I say, make sure it's music the patient likes. I told my sons, if you ever put rap music on when I'm dying, I will come back and haunt you forever. But know who your patient is. I know one gentleman that their sons recorded 27 hours of his favorite football championship games, and that's what he listened to as he was dying, and then also overcame the death rattle. So be very respectful of the noise that people have. And also the noise in the room in general, because for example, I know in nursing homes, sometimes staff has thought, well, we don't want them to feel alone, so they turn on the TV. Do we really need to hear, the news these days while you're dying? That may be very disruptive, unless that person's like to do that 24 hours a day, which might be okay, but be very respectful of the kind of noise that's in that room and how you utilize that noise for somebody, even in their coma. Circulation. Again, you're not going to see this with everybody, but if you've got some heart and lung issues, most likely you will. There's a part, again, where I said that the heart's working very hard, and there's a time at which the heart goes, I'm exhausted. I can't get blood everywhere, so I'm going to make sure it goes to the most important places. So that's my brain, my lungs, my kidneys, my liver. So arms and legs, not so important, right? So they get cold, and they get that mottled purple or pink on the palms of the hand or the soles of the feet. So instinctively, the caregivers think, oh my gosh, I've got to cover them with a blanket. Then even in a coma, the patient kicks it off. Well, again, they are the expert inside their body, because what's happening is that blood is being concentrated in their torso. They might even have a fever we need to treat with. So let the person be the expert of what's going on, and just a light sheet is probably all they're going to need. Okay, agitation. This is when, like, somebody's maybe, getting close to death and they've been very comfortable, and suddenly they're squirming around and you don't know what's going on. And again, that's scary for folks. The number one reason for that, everyone I'm sure online has experienced, which is full bladder. You know what it's like to have a full bladder and you got to sit here in a classroom, right? So that's number one. Even if a person has been incontinent, sometimes it's just a spillover. It may be that their bladder's never quite emptied all the way because the message isn't getting to there. So make sure there's a healthcare professional who's checking the bladder for good emptying. That's number one. Number two, as I mentioned before, is the bowel movement. Make sure that that's still going. After that, then we have to figure out what's the history. Is it oxygen? Is it pain? Or is it the patient's history? And this is where it's really good to know who they are and where they've been. So for example, I was admitting a gentleman to hospice home care once, and he was past the point of being verbal. He had a Spanish-speaking caregiver only. His 2 sons and daughter had flown in from across the states to be with him. And as we were going through the admission process, it became more and more agitated. And so not having any medications available or anything, I thought, well, music is very powerful, so why don't we put on music from his childhood? We saw some Yiddish paraphernalia in the corner of the room, so the kids put on some Yiddish music. Well, the agitation turned into a cry, and that cry turned into an anguished cry. It was the cry that just shot through your body. It felt like the cry of a mother being separated from a child, or a child from mother. I mean, it was horrible. So I stopped everything and I said, whoa, tell me his history. Well, only the son had heard this story from this gentleman's sister. He was apparently in Poland during the Holocaust. And at the age of 16, he was being snuck out at midnight by himself. His family refused to come. And she had described her brother as banging on the door and crying to be able to say goodbye to his mother, who would not answer the phone. And he was banging and crying. And with that, oh my gosh, this is that cry. This is that cry. So what do you do now? So what we did is we fast forwarded his life. From Poland, he went to Mexico. And in Mexico, he felt safe. So we put on some Mexican music, and that actually settled him down in the meantime. I bring this up because if anyone has had any PTSD, whether it's due to wars, sexual assault, physical assault, etc., if they haven't confronted that during their regular lives, sometimes it can come back to bite them at this time. So being aware of what those dynamics are and seeing how you can move them through that is going to be very important. Another one of the interesting phenomena are energy surges. This is when somebody is actively dying, maybe they're in their coma, and suddenly they wake up and they're talking with you, and you go, whoa, what happened? Is it a miracle? No. Why does it happen? Don't know. There seems to be an element of opportunity for closure in that, but I think it also gives us a glimpse into the mystery of dying and reminds us that people are still fully intact human beings no matter what they look like on the outside. So for example, Jean Houston talks about her grandmother in Sicily who had been in a vegetative state for 7 years. Total care, total feed, no communication, zip, nada. Now she's actively dying and the family had filled the room. And her grandmother wakes up and starts talking. And she's talking to people she sees on the ceiling. And they said, well, Grandma, we don't see anyone up there. And she goes, well, yeah, because they've come for me. They haven't come for you. And she goes, well, I don't get it. You've been like a vegetable for 6 years. What? And she goes, but the places I've been. So we can look at people who have severe dementia or not responsive and curled up and think, what a horrible life. But maybe they're living it up in there. And maybe their existence is just to remind us again that they are fully human beings worthy of our care and attention, no matter what. So this is one of the wonderful mysteries, I think, and I've seen it more often with dementia or with liver disease. Okay, let me switch over to communication, because this is a biggie, because the only thing harder than talking about dying is not talking about it. This is your opportunity to say some things that you may not have said in your whole life, and you need to get some closure for that, which is really important. So that's part of our work and has been in hospice of how do we get to that closure? How do we facilitate that communication? And realize that some people will hold on until someone says it's okay to let go. I remember one young woman, she was in her 40s and she was dying of kidney cancer, and her son and her daughter knew that she would never go home again. She was in the hospital. But she kept holding on, and we thought, wow, what's going on? Well, I finally overheard it. Her son and daughter were holding her hands on either side, and they said, Mom, you're going to get better. We're going to get you eating again. We're going to take that trip to Hawaii that you want. We're going to get you out of here. So what Mom heard was, they're not ready to let me go. So in overhearing that, I then pulled the husband aside and I shared with him what I had heard. And then he pulled the kids aside and they came back later. And they grabbed her hands again and they said, Mom, we love you. We're going to miss you. And we're going to be okay. And within 10 minutes, she let go and she died. So sometimes we look at what holds people on. Are they worried about who's going to care for their husband with Alzheimer's? Are they worried about who's going to care for their 30 cats? Whatnot. Now, it may not be possible for people to say it's okay to die now. And that's okay, because it's not okay for you. But by simply sharing what you remember and love about them is a way to get closure. But if you do want to say it's okay to go, I just say, just say it once. Because I've seen the families where they're with their grandma going, okay, Grandma, it's okay to go now. Day 2, Grandma, we said you could go now. Day 3, Grandma, Grandpa's up in heaven waiting for you. What's up? And I said, well, okay, 3 things need to happen. You need to let go of your grandma, and you did. Great for you. But grandma needs to let go of you, and then grandma's body needs to let go of her. So again, just trust the process. We can't dictate this one. Not all closure is pretty, but it's important. There are families that, you know, there's been conflict and whatnot, and they all come together and they John Boy Walton sing Kumbaya and together and forgiveness around the bedside scene. And that's wonderful when that happens. But what's also true is if somebody's been mean, cantankerous, and angry in life, chances are still good they're going to be mean, cantankerous, and angry and dying. So the family member or the son who's waited 50 years for dad to say, I'm sorry, or I love you, may not get that. And that's why bereavement is going to be important. But closure may not be pretty, but it's still going to be important. There's stories about that, but I don't have time, unfortunately, to cover that at the moment because I want to give you time for questions at the end. So the most beautiful thing we can experience is mysterious. And this is where my patients have been my very best teachers and really changed my own experience of dying and belief systems. So let me talk about the timing of death, because this is, I think, critical that I talk about this early. And again, I check this out with all hospice and end-of-life workers, actually internationally. I truly, truly believe or know that people choose their time to die. And I let families know, if you're supposed to be there, you will. If you're not supposed to be there, you won't. Do not put a judgment on that. You were good because you were there. You're bad that you weren't. Your relationship is not defined by those last minutes at all. People carry guilt for years of saying, I wasn't there. I just got up to get a cup of coffee. I just did something else. You weren't supposed to be there. Honor the fact that they have chosen a time and do not put any judgments on that at all, because people do have their own time and their own requests about that. I remember I was pronouncing the death of a woman in South Tucson, and the story came out from her son. He was having a hard time getting home from the war in Iraq at that time, and we weren't sure he was going to make it home in time before his mother died. And it was just kind of touch and go. But as soon as his plane landed at the airport on the tarmac, he flipped open his cell phone. He called home. His father put the phone up to his mother's ear, and he said, Mom, I'm home. I'm on the ground. I'll be home in 20 minutes. Her only wish was to get her son safe on the ground. That was her wish. So she whispered, I love you. And 1 minute later, she died. When the son told me this, I said, oh gosh, you got so close. And he goes, oh no, my mom knew me. If I had seen that last breath, it would have been difficult for me. But to have heard her sweet voice and then see her in beautiful repose, he goes, that was perfect for me. And for her, my son is safe. He's on the ground. I can go now. And I'm sure you've had plenty of those stories of people waiting till somebody shows up or waiting till somebody leaves to die. One of the other great mysteries are visions. And again, I didn't used to believe in visions. And it doesn't matter if you don't believe in visions either. What matters is if you've got somebody who says they're seeing something, it means something to them. And it really behooves you to kind of find out what they're experiencing, what they're seeing, and gives you a glimpse into this kind of unknown. Now, I don't call them hallucinations unless it's black bugs or spiders. That's usually a problem with a narcotic. We're going to change the drug. But anything else, I'm just going to ask them what it is. It's very common for people to see children, animals, religious figures. It doesn't matter whether their belief system is or not. They've seen something. What you'll see in this picture here is actually a picture of my mother, actually when she had a fractured hip. And she was talking to somebody, making the decision as to whether she was going to die or whether she was going to stay. And you can see the joy in her face as she was making that decision. She decided to stay. So sit back and bear witness to that. I had a patient, one cantankerous woman in her 70s. Oh my gosh. She got rid of that no good husband of hers years before. Thank God he was dead. Her interfering family, thank God they were dead. She did have a son and her daughter, but they were rather estranged, not surprisingly. And she did have some friends who had also died. So kind of a cranky lady. She had no belief system. When you're dead, you're dead. She really didn't want anyone to fuss over her. I was the only one who was allowed to visit her, rather begrudgingly. And the 4 months I cared for her in hospice home care, she never smiled once, just not what she did. She didn't want to talk about the dying process. I honored that. But the daughter and I did talk about it because she wanted to know. And the daughter had her own issues going on because she tried to become a nun and then was unable to complete the training. So she had her faith issues going on. Well, one day I visited and this woman was getting her wish. She was going down very quickly. I got her into bed and I called the daughter over. So now the daughter and I are on either side of the bed. And this woman is talking through her dying. Well, I had never seen that before. Now, people who are dying often talk in metaphoric or symbolic language. And the most common thing you'll hear is, I want to go home. Whether they're home or not, they're talking a whole nother home. So I say, listen with the third ear and see if you can figure out the meaning behind whatever they're saying. And in this case, this woman was lying there saying, where's the bus? The bus is late. Okay. Wasn't sure what to do with that one. So I said, well, the bus will be coming. And then I got a little braver and I said, and family members will be there to help you. And she goes, oh, giddy. I thought, oh God, I got to be quiet. She hated her family. So I shut up. Where's the bus? The bus is late. After a long while, she reported a bus showed up. I asked if that was okay. And she goes, yes. Good. Silence for a while. And then she said, I can't stay on this bus. This is the bus to hell. Get off the bus. I didn't know what else to say, but apparently it worked. I can't direct visions, but the patient can. So she did get off the bus because now we're back to, where's the bus? The bus is late. Well, after a while, she reported a white ambulance showed up. And I asked if that was okay. And she goes, yes. Silence again for a long time. Then everything in that room changed. This lady's body lit up with joy I had never seen. Her hands came up to her face. She was grinning ear to ear. And she says, look, there's a party. And they've been waiting for me all this time. And yes, I did find out later it was her friends at the party, not her family. So she was ecstatic. The daughter's on the other side of the bed from me, and tears are streaming down her face. And she said, I know you said this was possible, but until this moment, I didn't believe it. So here's a woman who, by sharing her dying process and her visions, reaffirms the faith of her daughter, but also gave me as a hospice nurse yet another piece and affirmation of, wow, what an amazing process this is. So there's a ton of stories about that too in the resources. So bottom line is, a good death does honor to whole life. If we can help prepare people for it so they know what to expect, how to provide the best care, to not make decisions based on fear, but to really know how to provide and honor the body's wisdom, then we've done the best preparation for death that we can. We're never going to take away the sting of death of somebody we love, but we can remove the sting of, I didn't know. So I will go ahead and open this up for questions that people have, or if you want additional stories or share anything, we'll go from there.
Awesome. Tani, thank you so much for sharing. Just like Tani said, we are going to transition into some Q&A time. So utilize that questions tab, send in your comments, send in your questions that you have for her, and we will just begin our discussion. So one question that we did have was, how do we start a dialogue with our loved ones about their wishes when it's that difficult time of letting go and they are no longer in that state to keep fighting? So how do we start that dialogue with them?
Great question. And it depends on the person, but what I always start in general is to find out where they are and what they really understand. Tell me what you understand about your disease right now. Tell me you understand about what your goals are or what the treatment may be. So I need to know that first. If they think, oh yeah, I'm going to be cured or something else, then we really got to get the physician and whatnot on board to have an open discussion. But that allows them to say, well, I'm getting worse, whatnot. And then you can say, what is it that concerns you the most? How can I best help you for this process? I really want to do the best job possible to support you in all this. So let's talk about what that might look like, or how I can best do that, or find out what your wishes are, because, this is hard on all of us. acknowledge that. So start with them and what they understand, and then it leads into a discussion.
Yeah, absolutely.
And that decision-making step, that'll be in the next seminar coming up too, navigating some of these pieces. And then I'll give you actually very specific handouts and verbiage for these sorts of things too.
Awesome. Going back to when you were talking about eating habits and when people reach that state of just no longer wanting to eat. So I guess, like, what's the time frame that you've witnessed where that's okay to start, like, accepting those wishes? What happens if they're elderly and they've been doing it for months and there's no signs of the actual death process beginning? As a caregiver, as a loved one, how do you honor their not wanting to eat, but at the same time, I don't think we're there yet?
Well, and that's where it comes into challenges with the disease process. So, for example, my mother has Alzheimer's. She started eating less, a year or two ago, and it continues to be less and less. So she may not be actively dying now, but she knows what her body can and can't take. So what we look at is, what does she prefer? She loves chocolate. Make sure she has some of that. But also, again, ruling out, is it they're not eating because of socialization, depression, they've got constipation? I mean, those things I listed on the slide, if those are all ruled out, then simply chat with them. And if they don't want to eat, they don't want to eat. And we just don't want to push it. It's not going to change the disease process, having them eat more or less when you're dealing with a chronic illness.
Interesting, yeah. Another section that you talked about that I just found super interesting and I had never really given much thought to, but was the agitation symptoms that you see. This is more of a comment from myself, but I just think about their life story and using that and integrating that and how you care for them. I just thought that was so beautiful. And so anyways, I loved that part.
Yeah, and that's what we also use, other modalities also. So for example, I had a patient on the unit who was adored, and his family was there. He was only 42 years old, and he became very, very agitated. And we were upping the pain medication so fast, we had no idea what was going on. So finally, one of our nurses who knew Healing Touch kind of did a little scan and kind of smoothed out. She sensed a lot of fear in his belly. And so she did her little technique over them and settled them right down. So that's why I say we've got to figure out, we got to be sleuths to say, is it fear? Is it pain? Is it history? We don't know. So that's why getting people to tell their stories is really wonderful.
Yeah, I totally agree. Okay, another question we received was, do you find that oncologists are getting more comfortable about discussing end-of-life issues?
That's kind of loaded. I work with some who are always fearless with that, and they're really very good because they see them as they've gone through it with their own family members and they really understand it. Others have difficulty until it's actually in their face, and still, even now, 12% of patients are getting chemotherapy within 2 weeks of dying. That means people aren't usually talking to them. So I think it's really variable. So I think it's good for people to ask ahead of time, when it gets to this point, I need you to talk to me honestly, if that's what you want, because I want the best care possible. And the best care may not be, active treatment. If that oncologist, and again, we'll talk about it in the next session, feels that death is failure, then it's going to be harder for him or her to want to stop treatment. So there's a lot of dynamics there. And there's also family members who say, don't give up on me, don't give up on me, when it's really not the best care to keep treating. Again, we'll talk about it in the next session. But I wish I could always point my finger to one issue or another, but it's all of us together having open and honest discussions.
That makes sense. Okay, we actually have one more question. What are some techniques or tools that I can use to be okay with dying, and how do I share that with friends and family?
I don't know how to respond to techniques or tools. I mean, I certainly have my other video and books on the resource page, but I think just being comfortable when you've seen a good death yourself, you carry that sense of knowing and peace with you that you get to share with others when you're there. Your presence is phenomenally important. So it's always checking in with yourself of what frightens me, how do I feel about it. So maybe even taking classes in death and dying, or the dying process and whatnot, helps. And when you're actually there, you get to be human. You know, I remember a hospice director dying, and she was totally loved by all of us. And here we are, 14 hospice professionals in her room, disagreeing about what to do, what the care, our nervousness, got to be just right. And sometimes it's just letting it go and make sure that we're focusing on the person and that we're responding to what they seem to be needing and wanting, rather than our own selves and our own performance and whatnot. I guess life is just about lots of letting go. So how do you prepare for it? I don't know, other than to be knowledgeable what the process is, be knowledgeable about what the best way to provide care by honoring that body's wisdom might be the best that you can do. I'm not sure if I answered that question, so let me know. It was kind of a big question.
Yeah, it was. No, I think that's great. And I like that you mentioned the resources that you provided. I'm just going to mention it again. If you haven't downloaded the handout that Tani provided for this webinar, please go to the handouts tab on your control panel and download that to save it. It gives you a link to the Pathways website and just gives you some good book and DVD ideas, as well as some articles and video clips. So definitely check out her resources. What were you going to say, Tani?
Oh, and also, I think I put it on that resource list too, is that people are also welcome to email me or call me separately if you want to talk about a particular issue, because I know it's kind of difficult with, you know, in this kind of format. So sometimes the questions don't come up until later, which is okay.
Absolutely. Yeah, for sure. Well, Tani, thank you so much for spending this time with us. We really appreciate you sharing on the dying process topic, because it is, it can be uncomfortable to talk about, but like you said, I think it's important to do it. And so thank you for leading the discussion today.
Well, thank you so much for the opportunity to take care of that fear.
Yes. I just want to thank everybody else who attended this session. Thank you for the questions. Thank you for the comments. Stay connected with our foundation. Visit our website. Again, that's texasoncologyfoundation.org. Like us on Facebook. There are some upcoming events, the Survive and Thrive symposiums that we host all around the state. The fall schedule is going to be posted soon, so be on the lookout for those locations and dates. And then plan to join us next month for our webinar in June. It's going to be on June 13th. It's from 4:30 to 5:30 p.m. And Dr. Erin Lampson, who's a pediatric hematology oncologist at Texas Oncology Medical City, Dallas. She is going to be joining us, and she is going to be talking about life and health after pediatric cancer, focusing that discussion on the prevention, detection, and treatment options for late effects of therapy. As we bring this presentation to an end, there's going to be a survey that's going to open up on your screen. Please take a moment and just provide us with feedback on today's presentation. And also let us know any topics that you would like to see covered in future webinars. Thank you all again, and I hope you have a wonderful afternoon.
Thank you all for coming.